So what is spirometry? The word spirometry, it is a Latin word, okay? And spiro means to breathe and metry means to measure, okay? So this method is used for assessing the lung function, okay? Measuring the volume of air of that patient maximally during inspiration or expiration, okay? We are measuring that volume. So what are the types of spirometers? So in our clinical classes, we have seen that there were patients who came with complaints like shortness of breath, coughing, then coughing out blood. Okay, so if they suffered from any disease, so it should be diagnosed, na? So the respiratory patients, if they are diagnosed or if they have come with certain types of symptoms to you, so in those patients you will be measuring their lung function test, okay, or pulmonary function test. So with these spirometers we will be measuring those patients, okay. So these spirometers are divided by two principles, okay. One is by measurement principle and one is by function or application, okay. So the first one is volume displacement spirometers. So our traditional spirometers, okay, we have one in our lab, and these flow sensing spirometers, they follow the principle of measurement, okay. And by functional application, these four, okay. One is peak flow meters, one is digital spirometer, one is incentive, one is whole body plethysmograph. So this peak flow meters, since you were there in our last class, we have shown you one with that handheld meter. We have given that blow and we have calculated it with the formula, okay, according to the weight or height of yours, okay. There were particular number, okay, on that basis of that predictive value and observed value we have calculated it, okay. So that was handheld, okay, or peak flow. And there are digital meters also, and incentive we have in that lab, okay. There are small balls, okay, green, then yellow, then red, okay. On that we measure the capacity of that lung. So this is mainly for exercising, okay, of the pulmonary function. And one is whole body plethysmograph. This one, what happens, we keep the patient in a glass chamber, and then there is a hole to balance the air pressure, and on that we measure the pulmonary function of that patient, okay. So I will tell you when we go to the next slides, okay. So what are the indications of spirometers? So this is a diagnostic test for asthma and COPD patients, okay. And apart from there are certain things for diagnostic indications, like evaluation of the signs and symptoms of a patient. Suppose a patient came with breathlessness or coughing, okay. So suppose he had for last 1 to 2 months, okay. So in those patients, whether there is a respiratory cause or not, or it is originating from other causes, okay. For in that cases we can do. Then evaluate the effect of certain disease on pulmonary function. Like so if the patient is having certain type of disease, if he is suffering from it, so he will have some symptoms. So on those patients also we will do that our spirometry for assessing the lung function. Then screening and early detection of individuals who are at risk of pulmonary disease. Suppose in patients like who are exposed to like dust, painters, okay, chemicals, then coal workers, coal miners, then who are working in the the mechanics, like who are working in the service centers, okay, reviewing their engines, then disc and braking, okay. During that time also there is exposure to the chemicals also, okay. So those categories of patients are early, or in those we can go for screening, okay. Those can develop those pulmonary diseases, okay, like asbestosis, okay, silicosis, okay. So in those category of patients. Then assessing surgical patient for preoperative risk. So in during any operation, okay, we take anesthesia fitness, okay, that patient is fit for operation. Okay, there are certain criteria, like we check the vitals, okay, then his pulmonary function. So in case of major operations, major OTs, and in certain daycare operation also, we check his pulmonary function, because if his pulmonary function is not good, okay, so that time when he will be anesthetized, he will be his motors and sensory activity will go down, na? So that time, if his lung function is not proper, so what will happen? His saturation will fall, na? If he can't maintain. So in those patients also we need to check, okay. Then assessing the severity and prognosis of pulmonary disease. So what is that? So suppose a patient has developed asthma or COPD. So during his initial stages, the pathology is going on. So how much it progressed, and from that position, whether it can be reverted back or can be recovered or not, okay. There also we can see with the pulmonary function, okay. So these are the indications. So these are diagnostic indication, okay. One is monitoring indications, like assessment of the efficacy of a therapeutic intervention such as bronchodilator therapy. So in patients like asthma patients, okay. So what we do normally, there will be bronchoconstriction. So if you give a bronchodilator drug like salbutamol to that patient, the bronchus will be dilated, okay. So we can differentiate, okay, whether it's getting dilated or not, okay. So in those patients, this can be a therapeutic intervention, okay. Then the second one is describing the course and progression of a disease that is affecting pulmonary function, such as interstitial lung disease or obstructive lung disease, okay. So that same one, how much it is progressing or not, okay, at which stage it is present, okay, like interstitial and obstructive lung disease, okay. And then monitoring the pulmonary function in individuals with high risk job, okay, that high risk patients, okay. In those patients also we can monitor, okay, whether they are developing it or not, or whether they have developed it or not, okay. Then sampling data can be used for epidemiological survey. So suppose in a particular group of population, they are mostly related to like exposed to smoke or like chemicals, okay. So this collecting this data from that area can be used for epidemiological survey, okay. Like how much is the disease progression, whether the whole population is involved, or how much population is involved in that particular group of population, and how much the disease has progressed, okay, and whether it can be treated or not, okay. These all will come in epidemiological survey, okay. In those patients also we can do this. These are monitoring indications, okay. So what are absolute contraindications? So indication means in which group of patients you will be doing, okay. One is absolute, and one is diagnostic, and one is monitoring, okay, in indication. And for contraindication, one is absolute contraindication. Contraindication means in which category of patient we can't do this test, okay. So there are again certain group of patients, like a patient who is hemodynamically unstable. Unstable means suppose his BP is more than the normal, okay. Like if he is like hypertensive, any emergency has happened, like any brain stroke has happened, okay, and or the patient is in shock, like his BP is less than 80, okay. In those type of patient we can't do the pulmonary function test, okay. Then recent myocardial infarction or acute coronary syndrome. Suppose any myocardial infarction has happened, any heart attack has happened, okay, in a patient, or any coronary syndrome, okay. There are certain coronary syndromes like ischemia, okay. So in those patients we can't, okay. Then in respiratory infections also we can't, or the patient had the recent pneumothorax or pulmonary embolism, okay. Respiratory infection like pneumonia, okay, or tuberculosis, okay, in those patients where there is active infection is going on, okay. Then a large aneurysm more than 6 centimeters in thoracic or abdominal aorta. Okay, aneurysm means abnormal dilatation of the artery. Okay, if it is more than 6 centimeters, okay, it can be thoracic or abdominal. In those patients we can't. Then hemoptysis, patient is coughing out blood or active blood is coming out. Okay, in those patients we can't. Then intracranial hypertension, when there will be raised in BP. Suppose if the BP is more than 200 or 220, so that in those patients, the patients might go to have stroke. Okay, cerebrovascular accident. So that time the cerebral pressure will be more. Okay, intracerebral pressure will be more. So in those patients also we can't. Okay. Then the 7th one is retinal detachment. So it is an emergency of the retina. Okay, where the retina is detached. Okay, from the anatomical position. Okay, it is an emergency. So it should be. In those patients also we can't. These are all absolute indications. So we can't do this. Okay, and one is relative indication, contraindication. Okay. So what is the difference between absolute and relative contraindication? Absolute means we can't. Okay, we can't consider this patient. Relative means sometimes if there is emergency in those cases we can consider, but most of the time we don't. Okay, so who are at active or suspected infection. Okay, transmissible respiratory or systemic infection. Then in hypertensive crisis. Okay, what is the difference between hypertensive crisis and hypertensive emergency? Hypertensive emergency में क्या होता है? There is already an accident occurred. Okay, due to raised in BP. Okay, and crisis means हो सकता है, it can be considered. Okay, and then facial pain in children's and patients with dementia. So children's and patients who are like old age patients, okay, who are having memory loss. Okay, so we cannot explain the procedure to them and they might give errors to the result. Okay, so in those patients we can't. So you understood now the difference between absolute and relative contraindication. So the next is volumes and capacities. Okay, one is static and one is dynamic. Okay, so what is static lung volumes? So in static lung volumes there are tidal volume. So what is tidal volume? So the amount of air which we breathe in, or okay, not and, it's or, okay, or out of the lungs during quiet respiration. So normally when in quiet environment, when we take inspiration and expiration, okay, or expiration, okay, either of the one, not both. Okay, so it is normally 500 ml. Okay, then the next one is inspiratory reserve volume or IRV. So it is the maximum amount of air that can be inspired after completing a normal tidal inspiration. So it should be starting from the end inspiratory position. So what is that end inspiratory position? So it should be taken from end inspiratory position. What is end inspiratory position? So when you're taking normal breath, okay, the height of inspiration where you end, that is the end inspiratory position. From that point you have to take a deep and maximum breath in. Okay, so how much is the volume? It is 200 to 3200 ml. Okay, and what is expiratory reserve volume? Not forceful. So it is the maximum volume of air that can be expired after a normal tidal expiration. Okay, or you can specifically say after end expiratory position. Okay, when you are normally exhaling, okay, at the point where it ends, from that position is known as end expiratory position. Okay, from that position you have to exhale. Okay, maximal exhale. Okay, so it is around 750 to 1000 ml. Okay, what is residual volume? So after maximum forceful, yes. The amount of air, yes, the volume of air which remains in the lung after maximal expiration. Okay, it is around 1200 ml. Okay, then comes the capacities. Okay, what is capacities? So capacities are addition or summation. Addition or summation of two or more volumes. Okay, so what is inspiratory capacity? Inspiratory capacity क्या है? It is the, you should be specific to the words which you are using. Okay, from where you are counting, from where you are measuring, it should be specific. Okay, so it is the maximal volume of air which can be inspired after completing tidal expiration. Okay, that is from the end inspiratory. Wait, let me go to the graph. Okay, so it should be from, if this is inspiratory capacity, from where it should be started from and expiratory. Okay, so normally you have to exhale in quiet respiration, you have to exhale normally, and from that you have to take maximum. Okay, so it is tidal volume plus inspiratory reserve volume. So it should be, what is this point? And expiratory, and expiratory position. Okay, and what is that? So one is functional residual capacity. What is that functional residual capacity? After normal tidal expiration or end expiratory position, the maximum amount of air which is present. Okay, you have to exhale forcefully. Okay, till here it will come. Okay, the total. Okay, the air remaining as well as this. Okay, expiratory reserve volume. So summation of these two will be functional residual capacity. And what is vital capacity? So how will you tell? You cannot tell plus. How will you tell? How will you describe it? So this can be again calculated. Okay, if you are taking from this position, this is which position? This is end of expiratory reserve volume. So after maximum exhalation, okay, from that point if you take a deep breath, okay, if you take deep and maximum breath, it will go here. So summation of these three, this one and this one. This is expiratory reserve volume, this is tidal volume, and this is inspiratory reserve volume. Or it can be also calculated if you take a deep maximum breath, okay, from that point if you forceful expire, jitna ho sake, okay, same. Okay, from expiration also it can be calculated, from inspiration of maximum inspiration also it can be calculated. Okay, and what is total lung capacity? So this is the summation, okay, of all the volumes, okay, or the functional residual capacity and the inspiratory capacity. Okay, this vital capacity, it is the maximum volume of air which can be expelled from the lungs by forceful effort following a maximum inspiration. Okay, this normally it is 4,800 ml in males and 3,200 ml in females. Okay, functional, it is the volume of air which can be contained in the lungs at end expiratory position after completion of tidal expiration. Okay, FRC is equals to RV plus ARV. Okay, then total lung capacity, this is the volume of air contained in the lungs after maximum inspiration. Okay, maximum inspiration means from where? So I told if you start from this position, this is which point? End of expiratory reserve volume. So if you take a deep and maximum breath from here, so this much is the vital capacity, and the remaining is the residual volume. So if you add this and this, vital capacity and the residual volume which is remaining, so if this will be from here to here, so this whole is total lung capacity. समझ में आ गया ना? Or you can start from the top also. Okay, it is written maximum inspiration, but it can be considered from that position also. Okay, from here to here, and then the remaining is the residual volume. Okay, okay. This is the graphical representation. Understood, na? This one? Understood. Okay. So this one is the end inspiratory point, and this is the end expiratory point. Okay. This is the tidal volume. Okay. Spirometer showing various volumes and capacities. Okay, fine. Now, one is dynamic lung capacity. Okay. Volumes and capacity. So what is the dynamic lung volumes and capacities? So static means it is not time bound. Okay, it is not time bound. You can take slowly also, you can take fast also. Okay, it is not time bound, but in dynamic it is time bound. Okay, Like if we the first point is timed vital capacity, so or TVC or forced expiratory forced vital capacity. Okay, so what is that? So here we tell the patient to take a deep inspiration or then forceful expiration, okay, in 1 second. Okay, there are 3 components. One is in 1 second, one is in 2 seconds, one is in 3 seconds. So we have to see the watch, okay, and on the basis of the timing, if it is in 1 second, you have to do it fast. If it is in 2 seconds, you will get more time. If it is in 3 seconds, you will get further more time. So the maximum effort or the maximum measurement we will get in the 3 seconds or in the first second. Which one? Understood na? Why 3 seconds? You are getting more time na? In 1 second it is not possible to take a deep breath and fast exhale. So it will be more in the 3 seconds, okay? Or forced vital capacity in 3 seconds it will be more, okay? So in first second it is around like 75%, okay? FEV, then in 2 seconds it is around 85%, okay? And in FE forced vital capacity in 3 seconds it is around like 95 to 98%. So maximum we are getting it in 3 seconds, okay? Then what is forced expiratory flow during 25 to 75% expiration in normal? So here we tell the patient to take again deep inspiration and expiration in 0.5 seconds. 0.5 seconds. That was in 1 second, 2 seconds or 3 seconds. But here we tell the patient to take a in 0.5 second to inspiration and forceful expiration. Okay. So here we calculate the mid portion. Okay. 25 to 75% में जो बीच का portion है in 50% we calculate it from that position. Okay. We take a mean from 3 readings. We take a mean and then we calculate it. Okay. So in normal patient it is 300 liters per minute. Okay. So it is actually calculative. Okay. So this with the help of this we understand that whether the patient is having obstructive or restrictive. Okay. Mainly it helps us to diagnose obstructive cases. Okay. Obstructive में lower respiratory. Okay. Like lower airways, smaller airways. Okay. In those patients, this helps us to diagnose the case. Okay. Then what is minute or minute ventilation or pulmonary ventilation? Here we tell the patient to take normal breath, tidal volume, okay, like tidal volume, inspiration or expiration for at least 1 minute, okay, and on the basis of that how much volume he is taking in inspiration or expiration for 1 minute, then along with it, the respiration. Tidal volume means what? Normally in quiet na. So in 1 minute how much is the normal rate? Respiratory rate?
12 to 16.
Okay. So if it is 12 to 16, suppose you have taken like 12 respiration in 1 minute. So normal tidal volume, like how much it will come if it is in if you calculate in 12 respirations. Normally it is 500 into 12, 6,000 are right. Okay. It can be more or less. Okay. There is a range, but normally it is 6 liters per minute. Okay. And what is maximum breathing capacity or maximum voluntary ventilation? So here it is also supposed to be calculative. Okay, again in 1 minute we tell the patient to take deep breath and exhale voluntary. Okay, so normally it is around 90 to 170 liters per minute. Okay, it is also in 1 minute we will calculate. Okay, that is the third one, minute ventilation also in 1 minute, and the maximum breathing capacity is also in 1 minute. Okay. Then the last one is pulmonary reserve or breathing reserve. Okay. This is the maximum volume of air which is the capacity which the patient got. It will be subtracted from the minute ventilation or pulmonary ventilation. Okay. This is calculative. Okay. We will find it out. Okay, with this formula. Okay, actually you need only the statics now, right now. Okay, dynamic is a bit different. Okay. So what are the diseases and what are the things you will get? How will you diagnose these cases? Okay. like the variations of lung volumes and capacities in obstructive and restrictive diseases. In obstructive diseases, remember that FEV1 means what? Forced expiratory volume in 1 second. Na? I told na it should be 1, 2, and 3. It was supposed to be done in 1 second. It is less than 80% of the predictive value. Okay. So among these all for obstructive cases, this is diagnostic. Okay. The fourth point is diagnostic. So if the FEV1 is less than 80% of the predictive value, so what is that predictive value? That calculation part according to that person, according to his weight and height, how much the predictive value is coming and what is the observable that you have done. Na? So according to that predictive value, if it is less than 80%, according to you, then if it is less than 80%, then you are having an obstructive disease. Okay. Or FEV1 by FVC ratio is decreased. Okay. So here the other conditions might be normal or increased. Okay. Like the total lung capacity is normal or increased in obstructive, then residual volume is elevated, then vital capacity is increased or decreased. Then what is supposed to be in case of restrictive disease? The total lung volume is supposed to be decreased. So do you know the difference between an obstructive and restrictive? What is that? Bronchioles. It can be anywhere, na? It can be anywhere. Okay, from the large till the smaller airways. Okay. So obstruction, like how the obstruction will be. So like suppose in bronchial asthma patients and COPD patients. Okay, COPD. What is the full form of COPD? So the disease itself is saying, okay, suppose you forgot in exam, okay, this you can remember from the name. Okay, so what happens there is constriction, okay, of the tubes or the linings, okay, the airways. Okay, so the outflow will be obstructed, it will be narrowed due to like inflammation. Okay, this is narrowed, or there is accumulation of mucus, the air is unable to release from the lungs on the, okay. So this is a obstructive type. Okay, here there is obstruction of the airways. And what is restrictive? In clinical classes we have shown you, we have described you. Obstruction means obstruction, restriction means restriction. Kahan pe? Restriction means something is not allowing the lungs to inflate or deflate. Okay, like, okay, in spinal deformities also, in ribcage deformities also. So spinal deformities like scoliosis, kyphoscoliosis, or okay, this. Then in ribcage deformities, one is pectus carinatum, okay, or pigeon shaped, or pectus excavatum, where the sternum is depressed inside. Okay, this is chest deformity. Okay, so in restrictive it can be originated from 4 locations. Okay, if it is from the bony or the anatomical, like these cases, so these are the bony or the anatomical cases. It can originate from the neuromuscular junction also. Okay, like in diseases like myasthenia gravis, Guillain-Barré syndrome. Okay, and one can originate from the pleura if you are going from outwards to inwards. Okay, pleura, like pleural effusion. Okay, these cases. So it is not allowing the lung to inflate or deflate properly. Okay, then pleural effusion. Okay, in the pleura, accumulation of fluid. Then it can be in the lung parenchyma. Okay, like pulmonary effusion or fibrosis. Okay, which is not allowing. So it can be from locations. Okay, so these all are restrictive. The restriction is there, so the lung is unable to perform its function properly. Okay, so here among these points, the most important point is the total lung capacity. Okay, so in restrictive cases, the total lung capacity will be decreased. Okay, and it will be less than 70%. Okay, this is diagnostic. Okay, and the rest other points you can also know it, like the residual volume will be decreased. Okay, then vital capacity, then FEV1 will be normal, and this ratio will be increased. Okay, so whether in restrictive cases there will be any obstructive problem in restrictive disease, whether there will be any obstructive disease. So in restrictive, what happens? I already told, it is outside. okay, and the passage is clear, okay, there is no defect in the passage. So the total lung capacity is only decreased, but the forced expiratory, see, this is forced expiratory volume, na? Forced expiratory volume. So when we will be blowing out, this is normal. Why this is normal? Because there is no obstruction in the airways. The externally it is obstructing, not the internal path. Okay. But if the passage, so if the obstruction is more, if it gradually progress, it might cause, because the force of expiration will be depending upon your inspiration, na? If you can take a deep inspiration, then only you will be having forceful expiration. If you cannot inspire fully, you cannot expire forcefully, na? So if it is massive, that time it might, okay, but it is not in the initial stage. Okay, fine, understood. And the procedure, उसमें तो we have already told you, know, the indications. कब करोगे, कब नहीं करोगे, वो उसमें अगर आता है तो you'll do. If it is not in that thing, okay, suppose the blood is coming out, okay, active infection हो रहा है उसमें, so you cannot do in those cases, ना. After it subsides, that time only you will measure the values. Okay. So what is the procedure? Okay. In our traditional machines, the spirometers, we have the one which you are having here. This is the vitalometer. Okay. So they are similarly, it is same look. It looks same like the traditional spirometer. Okay. But how will you differentiate between these two? Suppose whether this is a traditional or a vitalometer. So the main difference is that drum, okay, that chymograph, okay, where the graphical representation happens, that is present in traditional spirometer, but in case of vitalometer it is not present. Okay, but the rest of the function is quite similar. Okay, like there will be two cylinders. Okay, then it will be filled with 3/4 water. And the inverted bell will be present. Okay, then we will dip it in, then for few times we will blow in and out. Okay, so the air which is inside the drum or the bell, it is cleaned out, okay, with the fresh air. Then the subject is allowed to sit in a stool. Okay, and then then we clip his nose, and with the mouthpiece, after cleaning it, okay, we'll hold it with our teeth, the mouthpiece, and then with the lips we'll close it. Okay, then we'll blow, okay, according to the volumes. Okay, suppose you are measuring the tidal volume, then according to that we'll measure, okay, how much. Should we show them there? Okay, let's go and let us show you how that spirometer looks like, because okay, then the inner side, there is one inner chamber, okay, two chambers, okay, this one, inner one, and outer cylinder, okay, these two cylinders, and the water is present, and it should be placed 3/4. Okay, if you divide it into 4 portions, till third it should be, yes, till this third part it should be filled. Okay, and this is the corrugated tube, and this is the mouthpiece. Okay, disconnected, okay, to this outlet, and inside that inner cylinder there are two pipes. Okay, one is for inspiratory pipe, one is for expiration. Okay, expiratory. Okay, and it is connected with the help of a thread or string. Okay, in this disc. Okay, no, this is the disc. Okay, in the spirometer there will be this disc, but the measurement won't be there. Okay, in spirometer this will be helping in pulley, okay, during lifting and raising of the inverted bell. Okay, so this string with disconnected, and then it is continued downwards, and it is connected to a weight. Okay, with this weight we are just balancing the drum. Okay, the height, how much we are keeping, how much we want to keep it. Okay, this is for expiration. Okay, and this is for the height is the maximum height is for expiration. Okay, now this is for inspiration, and from here expiration. Okay, So this is dependent on volume displacement, okay, on measuring principle. So who want to be the subject? You want to be the subject? Okay, come. First clean the mouthpiece. So what is the procedure before measuring the volumes or capacity?
First you keep the mark at 0.
Okay. Mark at 0. So we have kept the mark at 0. Fine. Now so when the bell is up, it should be used for inspiratory. Okay. Inspiration. To the rock. And when the bell is down, okay, fine. So you want to measure which volume or which capacity you want to measure? First start with tidal, okay. So this will be which one? Tidal में which one? The inspiration or expiration?
Normal
Expiration. So if the bell is down, it should be expiration. Okay. So what is the procedure of holding the mouthpiece? Tell me first. अभी क्लास में absent थे आप?
नहीं सर.
The mouthpiece should be clean, na? You have cleaned it? Fine. Then the mouthpiece should be holded or fixed with your teeth. Then wait, before putting it in the mouth, then it should be covered with the lips so that no air is leaked. So since you are going for expiration, na? In tidal volume the expiration you want. So since you are going for expiration, then you have to first take inspiration. From where you will start? From an inspiratory point. Okay, in quiet respiration you take a deep quiet inspiration. From an inspiratory position you will exhale slowly. Okay, normally how you will exhale from that position. Then after inspiration, then put it into your mouth and then exhale slowly. No, this you are going beyond your normal exhalation. Okay, expiration. Normally you are exhaling the exhalation. It should be normal. Okay, it should be normal. Normal, take an inspiration. Normal inspiration, how you inspire? Exhale. This much, na? So you are going more deeper, na? So don't put so much force. It should be a bit more. Okay. So normally it is around 500. Okay. So you can. So if it is, suppose if I am putting it in 500, okay, from that position, try to now inhale. So from where you will start?
And
Expiratory point or position. Okay. So first exhale normally and then take inspiration. So it should be around 500. Okay. So during this, during inspiration, the pointer should be rotated, okay, in the opposite direction, because it is not possible, na? It won't go that. It won't go beyond this position. No? It is stuck there. So it should be in this position, okay. So this will be rotated. I will tell you. Okay. So anything more in inspiration? Any more volumes in inspiration?
Inspiratory is a word.
Okay. So this is for expiration, na? So we'll go to expiration. Anything? Expiratory volume. So from where will you start? The expiratory reserve volume.
And inspiratory.
And
Inspiratory.
not inspiratory. And expiratory.
Inspiratory. Yes.
So you will first take an inspiration. Take first an inspiration and exhale. Then from where it stops, this is the end expiratory position. From there you will exhale. Maximal. Okay. Okay. So it is around 1700. Okay, it came. So normally it is around
2000 to 100.
no. These are from 1000 to
1000 to 30.
around 1000 to 1500. Okay. So it came around. Okay, it came around approximately. It came. So this is an expiratory volume, okay, or expiratory reserve volume. Okay, so it is around 1500. So anything in more in expiration? No, or yes? Anything? So in expiration, these two. Okay, so now we'll go to inspiratory. Okay. So we are just moving the striker in opposite direction. Okay. Why we are moving it? So we are keeping it in 4000, okay? And the level of this is above. Okay, the belly is above. Okay, so if the belly is above, it will be considered for inspiration. Okay, because air is inside. Okay, so now which one you want to measure? So from how will you start? From where? Position. Okay. So what is the inspiration position?
First, I take inspiration.
Then inspire. Maximal inspiration. Okay. Do. Okay, so from 4000 it came around. This is 2000 and this is 2000, na?
Yes.
This is 2500 around 17. Okay, 2700. Okay, around 2700. So normal it is around 2000 to 3200. Okay, so the inspiration is double. Okay, from the expiration. We have told you that graph, that vesicular sound, how the inspiration, how the expiration. Okay, it is double the amount of air. Okay, so your expiration was around 700, not 700, 1700, and your inspiration is around 2700. Okay, so it is almost double. Okay, so what you have calculated? Tidal volume, then expiratory reserve volume. Okay, so these three volumes are known as
static.
It comes under static, but these three are known as vital capacity. Okay, and this is a vitalograph. Okay, so in vitalograph we measure the vital capacity. Understood? Okay, so what is the difference between this vitalograph and the traditional spirometer? So there I told there is a drum. Okay, so to measure the volumes, the static volumes, it should be rotated at a particular speed. Okay, 60 mm per minute. Okay, and for dynamic it should be rotated around 1200 mm per minute. Okay, for dynamic. Okay, and the static is for around 60. Fine. So what are the volumes which you can't measure? Total lung capacity. Why?
We can't. The decibel volume.
Yes, we can't measure. Okay, and any more? One is inspiratory reserve capacity. One is there na? Expiratory reserve capacity. Not inspiratory. The expiratory reserve capacity and the residual volume. These three you can't, because there is present of residual volume. It is present. Okay, we are not measuring the residual volume. We can only measure till expiratory. Okay, because it is left. We cannot count. Okay. So these are the points. So physiologically, when the vital capacity is increased or decreased, can you name? In athletes, okay, then in swimmers, then in divers, okay. So their lung capacity is more, okay. So the vital capacity increases in those persons, okay. Then when physiological condition, when it is decreased, like physiological. You understand first what I am asking. I always tell don't answer if you don't. First understand the question, then filter and process it, then answer. Don't answer like this. So normally lung is collapsed. And if you don't know why you are answering, उसमें lung capacity ज़्यादा होता है, so the vital capacity is more. Okay, so in pregnancy, okay, normally when you are taking an inspiration, the diaphragm is pushed downwards. Now it is getting relaxed. Okay, so if there is any obstruction, something is not allowing you to relax the diaphragm, so the capacity will decrease. Okay, in pregnancy, due to the presence of gravity to us, okay, the capacity is decreased. Okay. Then in old patients, okay, not patients, like in old people, okay, what happens in during adolescence, it is maximum. Okay, during old patients, what happens, the elasticity of the lung or the recoiling property of the lung, it is decreased. Okay, it is replaced by fibrous tissue. Okay, in those patients also the capacity is decreased. Okay, so these are the physiological. Okay, so here we have shown you the obstructive and the restrictive cases. Okay, so this already has been told to you. Okay, so what is the diagnostic criteria for an obstructive disease? FEV1 should be how much?
Less than 80%
of the predicted value. Okay, predicted value means according to you. Okay, not average, not all, according to you. Okay, then for restrictive, even normal, it can be normal in normal patient also. Which one is the diagnostic? So the obstructive cases we can measure through the spirometers. Okay, the restrictive, it should be measured by which instrument? Can you tell? It is whole body plethysmograph. Okay, that one of the patient was kept in a glass chamber. Okay, in that method, in that machine, we can calculate the restrictive only that on that machine. Okay, and the diagnostic criteria is the lung capacity should be less than the total lung capacity should be less than 70%. Okay.